So here we will study about a pathology, traumatic pathology of the finger by the name of mallet finger. So as we have discussed in our anatomy sections, that the tendon of EDC, it firstly gets inserted over the base of proximal phalanx, forms a sagittal band, then a central slip continues to get inserted over the base of the middle phalanx, and two lateral slips which are joined by the lateral bands of the interossei and lumbricals to form a terminal tendon which get inserted over the base of the distal phalanx. So during the traumatic injury while getting hit by a football or baseball, there is a sudden flexion of the distal phalanx at the DIP joint which causes avulsion of the terminal extensor tendon from the base of the DIP joint. So this is known by the name of the mallet finger. So as the finger is in position of somewhat of flexion, so this is known as the mallet finger. So when a ball strikes the finger goes into the sudden flexion, which results in the avulsion from the base of the distal phalanx on the extensor side of the terminal extensor tendon, resulting in a flexion deformity at the level of the DIP joint, which is in the form of a mallet. So this is known as the mallet finger. Now it can be a bony injury or it can be a complete tendon injury. So it can be a mid-substance tear of the tendon, or it can be a avulsion fracture. Plus it can be a open injury or it can be a closed injury. So most commonly it is a closed injury, but in some cases it can be a open injury. So this is also now known by the name of the baseball finger. Now coming upon to the classification, we have a Doyle's classification. So in type 1 we talk about the closed injury, which can be with or without the avulsion fracture. So first criteria is it should be a closed injury. It can be a bony injury or it can be a tendon injury. So it can be associated with avulsion fracture or it can be a without avulsion fracture, only a tendinous injury, but it should be a closed injury. Then talking about the type 2 is the open injury. So in open injury, in type 2 we have a simple laceration. So in type 1, as we have discussed, it is a closed injury which can be associated with the avulsion fracture. In type 2, it is a simple laceration at the site of injury. In type 3, there is a gross tissue injury as well as gross tendon injury. So there is loss of tissue as well as loss of the tendon. So type 4 is classified into further three types. In type 4A, it is a physeal injury, mostly seen in the pediatric age group. So it is a physeal injury of the distal phalanx, physis. In type 4B, it is a bony injury, but the fragment is of the size of 20 to 50% of the articular surface. And in type 4C, the bony fragment is of more than 50% of the articular surface. So this is about the Doyle classification. So type 2 and type 3 are basically open injuries, and type 4 is associated with a small avulsion fracture, and type 1 is associated with small avulsion fracture and is closed injury. And in type 4, there can be physeal injury or it can be a fragment dependent classification. Now coming upon to the presentation, the patient will present with the typical history of the sudden flexion of the DIP joint. There may be swelling and inflammation at the level of the DIP joint. Plus the fingertip will be in the site. Fingertip will be residing in the site flexion attitude. So patient will come with the flexion attitude at the DIP joint because the extension is lost at this level. Now talking about the examination, there will be lack of the DIP extension. So if we stabilize the middle phalanx and ask the patient to cause the DIP extension, the patient won't be able to extend at the DIP level. Now coming upon to the X-rays. So X-rays are very important to detect the fragment size and any subluxation at the DIP level. Now talking about the management option. So first management option is the non-operative, which is the extension splinting. So we splint the DIP joint in extension. So it is important to note here that PIP joint should be free and movement should be initiated at the PIP joint, but DIP joint should be in the extension. Plus there should not be any hyperextension at the DIP joint. So extension splinting can be done for about 6 to 8 weeks. It should be done 24 hours a day. So what are indication of non-operative management? So it can be either a soft tissue injury, which is closed one, or it can be a bony injury, but it is a non-displaced fracture. So these are the two indications of this non-operative management by the extension splinting. Now in operative management, we can have a closed reduction and percutaneous pinning, or we can go for the open reduction and tunnel fixation. So important indication here is the volar subluxation of the distal phalanx. So in few cases where there is a volar subluxation of the joint, in those cases we should go for the operative management. And plus in cases where there is articular surface size is more than 50%, as we have seen in the 4C classification. So if there is articular surface size is more than 50%, we can go for the operative management. Now in chronic injury, if the patient present to us chronic more than 3 weeks of the injury, we can go for the reconstruction of the tendon itself. But it can only be done in those cases where there is a motion is preserved at the DIP joint. So if there is no motion preserved at the DIP joint and the injury is chronic type, we can go for directly for the DIP arthrodesis. Now among complication, no important complication is the extensor lag. So even after all these operative and non-operative management, the patient may have slight 10 degree of the extension lag. The last 10 degree may not be still possible because of the injury. An important complication last is the swan neck deformity. So swan neck deformity, as we have discussed in our previous video of deformity of the hand. So swan neck deformity is basically hyperextension at the PIP joint and flexion at the DIP joint. Now this occur if we immobilize the PIP joint along with the DIP joint. So while immobilizing the DIP joint, PIP joint should be freed so that the swan neck deformity doesn't develop. Now why does the swan neck deformity occurs? So if we immobilize the DIP joint along with the PIP joint, there occur a volar subluxation of the lateral bands, which results in the hyperextension at the PIP joint. So the DIP is already at flexion and PIP goes into the hyperextension, resulting in the swan neck deformity. So this was about the mallet finger. So important thing to remember here is the classification part, indication of operative and the non-operative management, and what all complication we can encounter. So kindly comment down below any queries or any suggestion, and thank you.